evening, everyone, and thank you for joining us. I'm Dr. Cami, AMPAT's pharmacogenomics specialist, and I'm excited to give you a glimpse into the fascinating world of pharmacogenomics. As Yolandi mentioned, I hold a PhD in pharmacy with a focus on pharmacovigilance, certification in pharmacogenomics from the University of Pittsburgh, and I currently serve as a member of the Clinical Pharmacogenomics Implementation Consortium. Before we dive into pharmacogenomics, let's first take a moment to discuss what pharmacovigilance is. Pharmacovigilance is the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects, or any other medicine or vaccine-related problem. The goal of pharmacovigilance is to improve patient safety and public health by ensuring safe and effective use of medicines. Pharmacogenomics acts as a valuable tool in the field of pharmacovigilance. Pharmacogenomics is a branch of medicine that examines how an individual's genetic makeup influences their response to medications. Pharmacogenomic testing identifies genetic variations in enzymes involved in pharmacokinetics and pharmacodynamics. This field is critical for predicting, preventing, and managing adverse drug reactions, a major public health concern, as adverse drug reactions rank as the fourth leading cause of death in the United States. While pharmacogenomics may seem like a relatively new field, its roots trace all the way back to 510 BC with Pythagoras. He observed that certain individuals experienced a fatal reaction after eating fava beans, a condition we now know as favism. These individuals were later found to have glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency. G6PD is an enzyme essential for the healthy function of red blood cells, and its absence can lead to hemolytic anemia, a potentially life-threatening condition in which red blood cells are destroyed faster than the body can replace them. Fast forward to 1950s, researchers discovered that genetic factors influence how a person responds to medication. In 1959, German pharmacologist Friedrich Vogel coined the term pharmacogenetics. Today, the terms pharmacogenomics and pharmacogenetics are sometimes used interchangeably. But strictly speaking, pharmacogenomics looks at multiple drug-gene interactions, while pharmacogenetics focuses on single drug-gene pairs. The Human Genome Project was a landmark global scientific effort whose signature goal was to generate the first sequence of the human genome. It began in 1990 and was completed in 2003. It was led by a team of international researchers who, in doing so, provided fundamental information about the human blueprint, which has since accelerated the study of human biology and improved the practice of medicine. So just some background with regards to genetics. Genes are the basic units of heredity found in every living organism, also referred to as the blueprints of a cell. Genes are made up of sequences of DNA arranged one after the other at specific locations on the chromosomes within the nucleus of a cell. DNA, or deoxyribonucleic acid, is a molecule made up of two strands that twist around each other, forming a double helix. Each of these strands has a backbone of sugar and phosphate. Attached to each sugar is one of four bases: adenine, thymine, guanine, or cytosine. When we refer to an allele, which we do often in pharmacogenomics, we're referring to two or more versions of a DNA sequence at a certain genomic location. Each person inherits two alleles, one from each parent, resulting in a diplotype. If the alleles are the same, we say the individual is homozygous, and if they're different, we say they are heterozygous. In PGX, diplotypes are typically expressed using star allele annotation. A single nucleotide polymorphism, or SNP, is a variation in a DNA sequence where a single nucleotide, A, T, G, or C, differs between individuals at a specific position in the genome. Essentially, it is a single letter change in the genetic code and is considered a common type of genetic variation amongst people. An allele represents a broader category of genetic variations at a specific locus, while a SNP is a smaller, more precise variation within that locus. These SNP variations can be used to study disease associations and individual drug response. PGX correlates gene expression or SNPs with pharmacokinetics and pharmacodynamics. In pharmacogenomics, pharmacokinetics refers to how the body absorbs, distributes, metabolizes, and excretes a drug with genetic variations, particularly in the enzymes like the cytochrome P450 or CYP450 pathways, affecting drug levels and clearance. Pharmacodynamics, on the other hand, describes how a drug acts on the body, including its interaction with target receptors or enzymes, and is influenced by genetic variants that alter drug response. Together, PGX uses insights from both pharmacokinetics and pharmacodynamics to predict individual drug response and guide personalized therapy. Drugs are classified into two main groups, active and prodrugs. Active drugs entering the body get inactivated during drug metabolism, while prodrugs get activated upon metabolism. The cytochrome P450 pathway or CYP pathways is responsible for 80% of drug metabolism. Genetic polymorphisms in drug metabolizing enzymes, examples CYP2C9, 2C19, 2D6, and transporters can significantly alter drug efficacy and toxicity. Some basic genetics nomenclature. So when we refer to a genotype, which we do often also in PGX, we refer to an individual's collection of genes from each parent. The mom is, if the mom is a CYP2C19 star 1 star 1, the dad a CYP2C19 star 2 star 2, the child will be a CYP2C19 star 1 star 2. When we refer to a phenotype, it's actually the clinical representation of the genotype or the actual observed properties, for example, blue eyes. If the child is a star 1 star 2 for CYP2C19 diplotype, it translates to an intermediate metabolizer phenotype. This means that the child will be an intermediate metabolizer for all the medications utilizing the CYP2C19 pathway. In pharmacogenomics, when we talk about phenotype, we're referring to how a patient's genetic variation is expressed clinically. There are four main phenotypes we focus on: poor metabolizer, intermediate metabolizer, normal or extensive metabolizer, and ultra-rapid metabolizer. Poor and intermediate metabolizers process medication more slowly. This can lead to drug accumulation in the plasma, increasing the risk of adverse drug reactions, and at the standard doses, they may not achieve the desired therapeutic effect. Normal metabolizers metabolize drugs at the expected rate, so the standard doses usually work as intended. There are exceptions to this rule. For example, tacrolimus, which is primarily metabolized by CYP3A4 and 5. In this case, normal metabolizers often need a higher dose to reach optimal peak and trough levels. Ultra-rapid metabolizers, on the other hand, metabolize drugs so rapidly that the medication may be eliminated before it can produce a therapeutic effect. It's also important to remember that drug efficacy depends not just on metabolizer status, but on whether the drug is in its active form when administered or is a prodrug that needs to be activated in the body. A relatable example is codeine, one of the most widely used opioids globally. Codeine is a prodrug, meaning it must be converted into its active form, morphine, via the CYP2D6 pathway. For CYP2D6 poor metabolizers, this conversion is inefficient, so they may not experience effective pain relief. However, the unmetabolized codeine can build up in plasma, potentially causing adverse effects. CYP2D6 ultra-rapid metabolizers bioactivate codeine into morphine at an accelerated rate. This can lead to dangerously high morphine levels in the blood, even at the standard doses, resulting in respiratory depression, confusion, or even death, all signs of morphine overdose. This example underscores the critical importance of pharmacogenomic profiling in optimizing opioid therapy and preventing potentially life-threatening adverse drug reactions. As we've seen, codeine is converted to morphine by the liver enzyme CYP2D6. Some individuals are ultra-rapid metabolizers due to CYP2D6 gene duplication. resulting in higher than expected levels of morphine, which can lead to life-threatening or fatal respiratory depression. The FDA has a black box warning on codeine prescription for ultra-rapid metabolizers and children. This is also applicable to breastfeeding mothers who are ultra-rapid metabolizers of codeine. The clinical utility of pharmacogenomics lies in its ability to personalize medication therapy by identifying genetic variations that affect a person's drug response. This enables healthcare providers to tailor medication choices, dosages, minimizing adverse drug reactions while maximizing treatment effectiveness based on an individual's genetic profile. The clinical validity of pharmacogenomic testing has been strengthened by the development of standardized interpretation and reporting guidelines, such as those from CPIC and PharmGKB, which I will review with you in the following slides. These resources empower clinicians and pharmacists to apply genetic information in clinical practice confidently, ensuring optimal medication selection and dosing to improve patient outcomes and reduce adverse events. The Clinical Pharmacogenomics Implementation Consortium, or CPIC, was founded in 2003 to overcome barriers to integrating pharmacogenomic testing into clinical practice. CPIC develops, curates, and freely publishes peer-reviewed, evidence-based clinical guidelines for drug-gene pairs, which are regularly updated. Through rigorous literature reviews and meta-analyses, CPIC provides genotype-guided dosing recommendations with high levels of evidence. PharmGKB is a trusted resource that compiles information on how genetic variation impacts drug response. It offers drug label monographs, including FDA labels and CPIC guidelines, and grades evidence by strength, where levels 1 and 2 generally represent actionable data suitable for clinical use. ClinPGX is a comprehensive clinical pharmacogenomic resource created to support and expand PGX knowledge, implementation, and education. It integrates the PharmGKB, CPIC, and PharmCat projects. Their goal is to make clinical PGX accessible and facilitate its integration with genomic medicine. Here's an example of a supra drug label that includes pharmacogenomic or genotype-based dosing guidance. Siponimod is prescribed for relapsing multiple sclerosis. And is contraindicated for poor metabolizers with the CYP2C9*3*3 genotype, who are expected to have little to no enzyme activity. Therefore, genotyping is required prior to siponimod initiation. The FDA currently includes pharmacogenomic information on over 600 drug labels, and many of these medications are used in South Africa, as we will explore over the next few slides. Clopidogrel is a commonly prescribed antiplatelet agent used to reduce the risk of myocardial infarction and stroke in patients with acute coronary syndromes and or following percutaneous coronary intervention. Clopidogrel, a P2Y12 inhibitor, slows down clotting by inhibiting ADP-mediated platelet activation and aggregation. Clopidogrel is widely adopted for its low cost and broad indications for use. It is a prodrug and requires bioactivation via the CYP2C19 pathway in the liver into its active metabolite. Conversion of clopidogrel into its active metabolite requires two sequential oxidative steps involving several CYP450 enzymes: CYP1A2, 2B6, 2C9, 2C19, and CYP3A4 and 5. However, in both steps, CYP2C19 has the greatest contribution of all these enzymes. The CPIC guideline for clopidogrel provides dosing recommendations based on patient metabolizer phenotype. However, for intermediate metabolizers and poor metabolizers, it strongly advises against the use of clopidogrel. These patients are unlikely to achieve the desired antiplatelet effect, putting them at an increased risk of clot formation and recurrent stroke or cardiovascular events. For intermediate and poor metabolizer patients, prescribing alternative antiplatelet agents like ticagrelor or prasugrel is recommended to ensure effective prevention of thrombotic complications. Simvastatin is widely used to lower low-density lipoprotein or LDL and total cholesterol levels. Statins like simvastatin help prevent cardiovascular disease and rank amongst the most commonly prescribed medications worldwide. The SLCO1B1 or SLOCO1B1 gene encodes the organic anion transporting polypeptide 1B1 or OATP1B1 protein, which facilitates the hepatic uptake of statins. This process allows the liver to clear these drugs from the bloodstream effectively. Genetic variations in SLCO1B1 or SLOCO1B1 can significantly increase systemic exposure to statins, raising the risk of adverse drug reactions. Increased systemic exposure to statins can lead to statin-associated muscle symptoms, or SAMs, which range from mild muscle pain, myalgia, to severe muscle breakdown, rhabdomyolysis. SAMs is the most common cause of statin intolerance. Patients who carry poor function or decreased function variants of SLOCO1B1 gene are at a higher risk of developing SAMs. This adverse effect often leads to reduced adherence to statin therapy, ultimately compromising its long-term effectiveness. This CPIC algorithm guides statin therapy for patients carrying SLOCO1B1 poor function alleles. Statin intensity, high, moderate, or low, is determined by the patient's LDL cholesterol level. The black boxes highlight various statins and doses associated with a high risk of statin-associated muscle symptoms in these patients. Warfarin remains the most widely prescribed oral anticoagulant globally. However, dosing warfarin is challenging due to its narrow therapeutic index and significant interpatient variability. Optimal dosing requires regular monitoring of the International Normalized Ratio, or INR, often involving months of careful dose adjustments. Diet also plays a critical role in influencing warfarin's therapeutic effect. Adverse drug reactions related to warfarin are amongst the most frequently reported to the FDA and are a common cause for emergency room visits. The pharmacogenomics of warfarin is complex, involving multiple genes in its metabolic pathway, including CYP2C9, VCORC1, CYP4F2, and CYP2C. CYP2C9 primarily affects pharmacokinetics, while VCORC1 and CYP4F2 influence pharmacodynamics. CYP2C contributes to warfarin clearance. This is the CPIC genotype-guided dosing recommendation for warfarin. Patients of African ancestry carrying the decreased function CYP2C9 *5, *6, *8, or *11 alleles generally require a 15 to 30% dosage reduction. In Caucasian and Asian patients, the *2 and *3 alleles are associated with increased bleeding risk, warranting a reduction in the initial warfarin dose. Patients with a VCORC1 G to A variant exhibit increased warfarin sensitivity and typically need lower doses. The CYP2C variant is linked to a 10 to 25% dose reduction, while carriers of the CYP4F2 *3 allele often require a 5 to 10% dose increase. Interpreting the combined effects of all four warfarin-related genes and their phenotypes can sometimes be conflicting. That's where clinical decision support software becomes invaluable. It integrates genetic information with key clinical factors to guide warfarin dosing more accurately. CDSS considers variables such as treatment strategy, baseline and target INR, ethnicity, pharmacogenomic results, medical conditions, and kidney and liver function. It applies these alongside established algorithms, including the European PGX of Anticoagulant Therapy, or UPACT, for loading dose, and the International Warfarin Pharmacogenomics Consortium model to calculate the optimal dose. For this patient using the CDSS approach, the calculated warfarin dose is at 5.5 milligrams per day. There is robust evidence supporting the use of pharmacogenomics in psychiatry. In a recent US ASPRI study involving over 13,000 adults aged 65 years and older, nearly 98.8% were found to carry at least one actionable genetic variant, most commonly impacting the CYP2C19 and 2D6 enzymes. Medication changes due to pharmacogenomic results included: of the 603 patients on amitriptyline, there were 26 dose changes, while 38 were taken off the drug. 393 on sertraline had 58 dose changes. 282 on escitalopram had 29 dose changes and 2 were taken off the drug. Of the 200 on citalopram, 27 had dose changes and 5 were taken off the drug. Of the 183 on venlafaxine, 38 were taken off the drug. And of the 157 on paroxetine, 41 had dose changes. These results support using pharmacogenomics to guide safer, more effective prescribing for anxiety and depression in older adults. Many believe that the current pharmacogenomic data may not be fully applicable to South Africa's genetically diverse population. Here's an overview of the predicted clinical relevance of pharmacogenomic variation in Africa, compiled by Dr. David Twesigomwe, a postdoctoral fellow at the Sydney Brenner Institute for Molecular Biosciences. Efavirenz, metabolized by CYP2B6, requires dose adjustments for a significant portion of the African population due to genetic variability. While efavirenz is associated with neuropsychiatric side effects, it is being phased out in favor of newer antiretrovirals like dolutegravir, which offer improved efficacy and fewer side effects. A 2020 study by Miller et al. Found that renal transplant recipients of African descent exhibited high CYP3A5 expression, significantly affecting tacrolimus pharmacokinetics. As a result, Black African patients require higher tacrolimus doses than their white counterparts. These findings highlight the urgent need for locally generated pharmacogenomic data tailored to our diverse population. At AMPATH, our targeted PGX testing approach specifically includes known African relevant alleles to address this need. The clinical utility of pharmacogenomics is illustrated in this case study of a 70-year-old woman with multiple comorbidities and polypharmacy. She presented with left lower extremity pain, generalized weakness, and major depressive disorder. At the time of enrollment in the all-inclusive care program for the elderly, she was prescribed 14 medications spanning various drug classes. Given her symptoms of left lower extremity pain and weakness while on a statin, along with inconsistent INR readings on warfarin, the clinician requested a medication safety review. Based on these concerns, the clinical pharmacist recommended pharmacogenomic testing to optimize her medication regimen. These were some of the pharmacist's recommendations, several of which the clinician implemented. The pharmacist advised switching from atorvastatin to pravastatin to lower the risk of statin-associated adverse effects, as pravastatin has a reduced potential for drug-drug interactions and myopathies. Additionally, fluoxetine was replaced with citalopram to better manage depression and anxiety while avoiding interactions with carvedilol that could lead to orthostatic hypotension. Pharmacogenomic testing revealed reduced SLCO1b1 function, which may affect statin clearance and intermediate metabolism via CYP2C9 and 2D6 pathways. Following these medication adjustments, the patient experienced symptomatic improvement. This case underscores the clinical value of preemptive panel-based pharmacogenomic testing in older adults to detect drug-gene interactions and prevent adverse drug events. As we see with the case study of polypharmacy, that PGX plays a significant role in determining drug response. However, there are several other factors that influence response to treatment. As mentioned, genetic variations in receptors, transporters during drug metabolism, diet drug interactions like your beta blockers and grapefruit, for example, and your warfarin and green leafy veggies, drug-drug interactions like your SSRIs and clopidogrel that may increase the risk of bleeding and in some cases reduce the effectiveness of clopidogrel altogether. Supplement and drug interactions like rosuvastatin and vitamin B3, increasing statin-induced myopathy, age and sex, comorbidities like renal and liver disease, and phenoconversions. So what is a phenoconversion? A phenoconversion is a phenomenon that occurs when an individual's genotype predicted drug metabolism doesn't match their actual ability to metabolize drugs. For example, certain drugs like cyclosporin can inhibit the SLCO1B1 or SLOCO1B1 and OATP1B1 transporter, leading to higher statin levels and potentially causing myopathy even in individuals with normal SLOCO1B1 phenotype. Phenocopying is the result of phenoconversion, where a person with a normal metabolizer genotype might phenocopy a poor metabolizer genotype if they take a drug that may inhibit a certain gene. The patient will then mimic a new phenotype as a result. Causes of phenoconversion include the following. Concomitant medications, so taking multiple medications that interact with the same drug metabolizing enzyme. Smoking status, smoking can induce certain CYP enzymes changing their metabolic activity. Liver disease, liver impairment can affect drug metabolism and lead to phenoconversion. Nutritional status, certain dietary factors can influence drug metabolism. Age-related changes in drug metabolism can also contribute to phenoconversion. Both inducers and inhibitors of drug metabolizing enzymes can cause phenoconversion, altering a patient's metabolizer status. The PROP Pharmacogenomics calculator helps clinicians systematically assess CYP2D6 phenoconversion when a patient's CYP2D6 genotype is known. In this example, the patient is a normal metabolizer for CYP2D6 based on her pharmacogenomic results. However, if prescribed fluoxetine, a strong CYP2D6 inhibitor, she effectively phenoconverts to a poor metabolizer. Clinically, she should be treated as a poor metabolizer when taking medications metabolized via the CYP2D6 pathway alongside fluoxetine. Clinical Decision Support Software, or CDSS, can assist clinicians and pharmacists in managing phenoconversions during medication prescribing and review. In this patient identified as a CYP2D6 normal metabolizer, tamoxifen, an anti-estrogen agent used in breast cancer treatment, may be administered at the standard therapeutic dose, contingent upon the avoidance of concomitant moderate to strong CYP2D6 inhibitors. These inhibitors can reduce the bioactivation of tamoxifen into its active metabolites, potentially compromising therapeutic efficacy. In South Africa, AMPATH is currently the only SANUS-accredited lab offering pharmacogenomic testing, ensuring that all testing meets rigorous quality standards. PGX tests can be requested for by clinicians and is available as a direct-to-consumer test. AMPATH's PGX 120 panel is a commercially available Thermo Fisher product that analyzes 36 genes covering 120 SNPs relevant to drug response. AMPATH's PGX 120 panel includes pharmacogenomic coverage for over 130 medications commonly used on the South African market across multiple medical disciplines. Please note that this list is continuously being updated as new evidence emerges supporting genotyping for additional drug gene pairs. At AMPATH, we offer select single drug gene pair tests as standalone assays. Our currently available tests include clopidogrel genotyping for CYP2C19 or ClopyGen, DPYD testing for capecitabine and fluorosyl metabolism, and TPMT testing for thiopurine metabolism. Pharmacogenomic testing at AMPATH requires a separate consent form that authorizes the transfer of genetic data to a third party in Canada for report generation. Self-collection kits are available, and testing can be performed using either a buccal swab or single EDTA blood tube. The AMPATH report features a color-coded table within the first few pages for quick reference. Medications are organized by medical discipline. Those listed in the green column can be taken at the standard recommended dose, while medications in the blue column require dosage adjustments or alternative prescriptions to minimize the risk of adverse drug reactions. The report provides detailed interpretations of specific drug-gene interactions. At AMPATH, pharmacogenomic report interpretations are offered to clinicians by our in-house pharmacogenomic specialist, along with counseling sessions for patients. This approach ensures that PGX results are effectively translated into clinical practice. Clinicians and pharmacists who request pharmacogenomic testing through AMPATH receive complimentary, subscription-free access to clinical decision support software. CDSS enables the healthcare providers to incorporate additional clinical factors such as liver and kidney function, height, weight, and allergies. By integrating these parameters with PGX data, the software generates tailored reports that provide a real-time overview of how a patient's genetics interact with their current medication. This facilitates easier identification of potential causative agents in adverse drug reactions. Pharmacogenomics represents the future of personalized medicine. However, several barriers to its widespread implementation remain. The first one being healthcare provider education. Many clinicians and pharmacists currently lack sufficient knowledge of pharmacogenomic principles and how to interpret test results, which undermines their confidence in applying PGX testing in clinical practice. At AMPATH, our in-house pharmacogenomic specialist supports clinicians and pharmacists with result interpretations and onboarding onto the CDSS. Additionally, patient counseling services are available at an extra cost. Cost and reimbursement. So the expense of pharmacogenomic testing poses a significant barrier for patients and healthcare systems, especially where insurance coverage is limited or unavailable. In South Africa, some medical aids cover PGX testing during hospitalization, but outpatient testing typically requires upfront payment, with patients claiming reimbursements afterwards. In many cases, submitting a motivation from the clinician supporting PGX testing for a specific patient can facilitate reimbursement. Medical aids do pay for single gene tests. Clinical utility and evidence. Some healthcare providers remain skeptical about the clinical utility of pharmacogenomic testing. However, substantial evidence supports its use in certain fields, such as psychiatry and for specific single drug gene pairs. In conclusion, I hope today's discussion has sparked your interest into the exciting field of pharmacogenomics and its significant impact on medication response and adverse drug reactions. Looking ahead, the future of medicine is poised to shift towards a more proactive, patient-centered approach where pharmacists, clinicians, and nurses collaborate closely as integral members of the healthcare team. Together, they will optimize medication management and improved health outcomes through the effective integration of pharmacogenomic data into clinical practice. If you have any queries regarding pharmacogenomics, please do not hesitate to contact me via the following email addresses. Thank you all for your attention. I'd now like to open the floor for any questions.
Thank you very much, Dr. Cami. I already have one question for you. Someone is asking if the services is available in Namibia.
So Unfortunately, we are not currently practicing outside of the country. If the patient is residing in Namibia and maybe takes a holiday to South Africa and gets testing done here, then yes, we'll be able to help the patient. Whoever the patient or whoever had the query, please just email me and we can see how we can work around it.
Okay, and then there's another question. Someone is asking, if 80% of medication is metabolized, the report is only on 122 drugs. Why can't pharmacists use their pharmacogenetic knowledge to predict some of the other drugs' metabolism according to a patient's genes?
So you would essentially need to have the genotyping results in front of you. And we don't only look at CYP enzymes. CYP enzymes are very much involved in phase 1, but we do look at transporters like SLCO1B1, OATP1B1, UGT1A1. All those ones are involved in clearance and other phases of drug metabolism. So as much as 80% of drug metabolism is carried out by your CYP enzymes, a lot of it is carried out by the other drug metabolizing enzymes with regard to clearance and elimination. Pharmacists currently can use their knowledge with regard to pharmacokinetics and pharmacodynamics. However, knowledge is very limited when it comes to the genetics. I myself had to go and get additional training overseas in pharmacogenomics in order to interpret the results. What we learn at a varsity level in South Africa is very limited, but I do know that they are working on incorporating pharmacogenomics into the B-Pharm curriculum.